Thanks, David, and thank you for all the resources that the Arthritis Foundation provides for our patients. Thanks to OrthoAlliance for putting together this webinar on this important topic, and I'm very pleased and happy to talk about the topic of hip arthritis, um, specifically about treatment, including surgical treatment such as total hip arthroplasty. Um, just a little quick background on me. I've kind of done a little bit of training across the country, but I started my undergraduate in Ohio State, my medical school at Wake Forest, and then did a residency back in Central Ohio with Mount Carmel Health System. I then went to the West Coast where I did my fellowship in orthopedic trauma surgery with a focus on hip reconstruction, and subsequently came back to join the Orthopaedic Associates of Zanesville in 2018, where my practice primarily focuses on hip arthritis, knee arthritis, and broken bones. So the first question that we were tasked with as presenters here was to discuss when to see a specialist. So specifically regarding the hip, seeing a specialist is something that you'd consider doing initially if there's an acute injury. So an injury that has caused difficulty with bearing a body weight, or an injury that causes something that we term mechanical symptoms. And so a mechanical symptom is a symptom that blocks motion of the joint or makes the joint feel locked or difficult to move in certain positions. And so when these type of acute injuries develop, that's a trigger to see somebody that specializes in orthopedics and hip disorders. Many of our practices in OrthoAlliance across the platform, and especially in Central Ohio, have walk-in clinics and orthopedic urgent care when these types of issues develop. You can come in and be evaluated by a specialist, oftentimes the same day. Now, that's in contrast to other more chronic forms of pain. So we all develop these sort of aches and pains throughout the course of our life with activities and things like that. And many times they're not a big deal, where you do an activity and you're sore for a day or two, and then it goes away, or it goes away with a little bit of rest. When those symptoms persist for longer, and I sort of arbitrarily tell patients a week or two, but it could be shorter than that, or it could be a little longer than that, depending on the severity. But the key thing is that the symptoms don't seem to be improving with a change to the activity. So if a certain activity brought on symptoms and then eliminating that activity doesn't improve the symptoms, or resting, or applying simple things like ice and over-the-counter medications like anti-inflammatory drugs like ibuprofen or acetaminophen, if those things aren't helping, then that would be a good time to see a specialist. And so when you come to the office and we evaluate the problem, and in this case, we're talking about hip arthritis, what treatment options are available? And so we always start with what we call conservative or non-surgical treatment. And this is typically decided after evaluation of the patient, oftentimes with imaging that might include X-ray. And then we discuss which of these non-surgical treatment options would be appropriate based on the diagnosis. And so when we're thinking about non-surgical treatment of hip arthritis, many times we start with looking at the activities. And so modifying the activities specifically for things that are acceptable to do with the symptoms that are present in the hip. Many times, decreasing the impact level of our exercises can help decrease symptoms in an arthritic hip. And so it has been shown that keeping the joint moving, keeping the joint active is beneficial. It does help to decrease some of the pain and symptoms. It's a little bit counterintuitive because patients often ask, well, if the joint's worn out, should I really be using it? And the answer is yes, but you want to think about the activities that are being done. And typically we think about low impact exercise. And so, the highest impact form of exercise would be, running out on a hard surface like concrete or asphalt. And some patients with hip arthritis can do that with some modifications, but lower impact forms of exercise would be things like swimming, maybe trail hiking, cycling, things that don't load the joint with as much body weight. There is oftentimes a role for physical therapy in treatment of hip arthritis, and physical therapy is different than exercise. They're not the same thing. And this Physical therapy is a program directed by a licensed physical therapist to focus specifically on motion, strengthening, and deficits that are present around the hip joint. In America, one thing that we talk about often is weight loss. Unfortunately, there's a massive epidemic of obesity in our population, and that does correlate to extra pressure on the joint. Just like we talked about, high impact running, things like that puts a lot of pressure on the joint. Extra body weight also puts pressure on the joint. So the non-surgical treatment oftentimes involves looking at the body mass and deciding if there's a safe way and an appropriate way to bring down body weight. That often goes hand in hand with some dietary changes. The diet can affect the body weight, but the diet can also affect inflammation in the body. And so, like we were talking about earlier, arthritis is really inflammation of the joint. And so there are dietary things that can be done and have been shown to bring down inflammation. And oftentimes, this would be referral or consultation with a registered dietitian. Moving up the ladder, we can then think about medications. And so there are many over-the-counter medications that are appropriate to use in the initial phases of arthritis. And the mainstay of these are what we call the NSAIDs. That acronym stands for non-steroid anti-inflammatory drugs. That would be the things like ibuprofen that you can buy over the counter. And they help to decrease pain in an arthritic hip because they decrease the inflammation. If over-the-counter medications aren't working, then you can talk with your provider about a prescription strength. There are some stronger forms of anti-inflammatory medications that are safe to use and potentially more effective that come in a prescription form. In addition to NSAIDs, you can consider using acetaminophen, which is Tylenol, an over-the-counter medication. And it can be used safely in combination with NSAID medications. Because it works by a different mechanism in our body. Rather than decreasing inflammation and targeting pain by decreasing inflammation, it's really blocking pain receptors and pain perception in the body. And so it can work synergistically with NSAIDs to help control symptoms. After medications that one would take by mouth, you could consider injections. When we're talking about the hip joint, injecting the hip joint with a medication is a little bit different than the average joint injection. Most other joints that you're going to hear about tonight, we can safely and effectively inject in the office. And sometimes that may be done with ultrasound in certain settings, but things like the knee joint, the shoulder joint, we can feel that joint beneath the skin and accurately introduce a needle safely into the joint and inject the medication. The hip's a little bit deeper, a little bit less easy to inject just by feel alone. And so if you're going to have your hip joint injected, I'd recommend you see a specialist that can do it with some sort of imaging. And that may be under X-ray or a portable X-ray style called fluoroscopy. Or you could sometimes do that with ultrasound, depending on the provider preference. The gold standard medication for what we inject that has been shown to be most effective is corticosteroid medication. So a steroidal anti-inflammatory medication. And again, it's targeting the inflammation in the joint to help bring down the pain and the symptoms. Besides steroid, there is a growing body of evidence and research that's supporting more biologic type anti-inflammatory injections. There's a product called platelet-rich plasma, which is actually essentially a concentrated filter of a portion of blood. So the patient actually has a blood draw from typically their arm, and the blood is processed to remove the platelets in the plasma, which carry the growth and healing factors that normally are present in our blood. We take that and inject it back into a joint that has some damage from arthritis, typically in the more mild or sometimes the moderate or medium types of arthritis. It can help to decrease symptoms, and there's some growing research to support this. We know that it doesn't restore the joint back to the pre-arthritic state. It doesn't cure end stage or the final stages of arthritis, but in early arthritis, it may be helpful. Lots of patients ask about gel injections, and as far as the hip is concerned, gel injections have never been FDA cleared for the hip. We do see some providers that occasionally use them off-label, but there is very minimal evidence in the orthopedic research to show that they're effective for the hip. After we've gone through discussing conservative management and figuring out which, if any, of those steps apply based on the symptoms and based on the severity of the arthritis for the patient, we then move on to considering surgical intervention. And when conservative treatment measures have failed, the surgical treatment for the hip is something called total hip arthroplasty. So a complete replacement of the ball and socket joint of the hip. And the general things that I counsel patients on when to consider total hip arthroplasty are what I have listed here, that the arthritis is affecting the quality of life, that it's impacting the day-to-day functioning, and it's something that bothers them on a daily basis. It affects the simple functions of normal life. And so for the hip, it's especially things like difficulty putting on shoes and socks, difficulty rising out of a chair. When the symptoms are severe enough to affect that level of activity, that's a good reason to consider surgery. We use an X-ray to help diagnose the stage of arthritis, and the joints that we replace are at a minimum in the moderate category of arthritis, but oftentimes the more severe form of arthritis. We also then have to consider the health of the patient. Not every patient is a good candidate to have a joint replacement surgery. And so we have to carefully look at the health status of the patient and make sure that their body is fit to undergo a major elective procedure. And then when it's all said and done, we have to discuss the benefits that can be had with joint replacement and the risks that are present. And what we always want is we want that teeter-totter to tip in the side of the benefits. We want there to be more benefits than risks to justify doing a surgery. So total hip arthroplasty, in a really quick 10-second nutshell, is basically where we go in and we remove the existing worn out ball. So on one side, this patient's already had their hip replaced. On the other side, I'm going to show you kind of what the components are, but the new socket, we call that the acetabulum. That's typically a metal shell that goes into the new socket. And that's lined with a material called polyethylene in most cases, which is basically a really durable, really highly processed plastic. We place a titanium stem into the femur. This can be cemented into the bone in some patients. In other patients, it can actually be pressed into the bone so that the bone will grow into it. And that stem is what supports the new ball. And so in a nutshell, that's really what a total hip arthroplasty looks like. There's several different ways of performing total hip arthroplasty. I'm not going to belabor this point, but depending on the training of the provider that you've seen, they may do it different ways. And really what it involves is how to expose the hip joint. There's several different described ways to get down to that ball and socket. There's what's called an anterior hip replacement. There's anterolateral, and this is kind of going from sort of the front pocket to the back pocket. There's a direct lateral and a posterior lateral. When I think about how to get to the hip joint, the key is really how do we get there in the least traumatic way possible? We want to get to the joint without disrupting a whole lot of muscle tissue so that we can let the muscle behave more normally after surgery, more quickly, help to speed the recovery. And so, it's not really just the location of the skin incision, but it's what you do with the muscle beneath the skin incision that helps with the patient function. And so my strong preference for how to replace a hip is with what's called an anterior approach. And so on the prior slide, that's the green line here. It's more towards the front. People hear about hip replacement from the front. That's what they're referencing. And there's been a lot of research on what may be the benefits of doing a hip replacement through that approach. The things that are most consistent in the literature and the research that's been done is less pain in the immediate postoperative period, quicker return to walking without assisted devices, a more normal walking behavior, so a more normal gait pattern, less presence of a limp after surgery, and importantly, a lower risk of dislocation and the avoidance of what's called hip precautions after surgery. The ability to do it anteriorly also helps with more consistent placement, especially of the new socket, the acetabular component. And when you think about this list of 5 benefit summaries here, it really boils down to 2 things. The first 4 are present because the anterior approach is muscle sparing. When we do an approach through the front of the hip joint, we can use a natural interval in the muscle where we're spreading one muscle one way, one muscle the other way. We don't have to actually cut through muscle fiber. And so if we preserve the muscle, it allows them to potentially behave more normal more quickly after surgery. And the improved placement of components helps because when we do this surgery in that approach, the patient's lying flat on their back and we can do the whole thing under intraoperative x-ray. So what do you expect after a hip replacement surgery? Briefly, the postoperative course is as follows. In most cases nowadays, for healthy patients, this is an outpatient surgery, meaning you can go home after surgery. You put your full body weight on the surgical lower extremity immediately after surgery. Patients are up and walking with a walker with some assistance, typically within an hour to 90 minutes after we've finished the surgery. With anterior hip replacement specifically, because we have been preserving of the muscle envelope around the hip joint, there are no precautions. And so it's really listening to the body, respecting the boundaries that the body is giving you, the signals that it's sending, but there's not a laundry list or even a small list of things that you can or can't do. You can't, not certain sleeping positions or sitting positions, standing positions. Those don't apply when the hip has been replaced from the front. Most patients walk with a walker for the first week and a cane in the second week. Most patients return to light, unassisted daily activities, so light things around the house without needing a whole lot of help in 2 to 3 weeks. But then after that point, gradually increase the activities that they're doing based on how they're feeling. Most patients are able to return to a pretty normal lifestyle in 2 to 3 months after surgery. Just one quick slide on the concept of hip precautions. So when I say no hip precautions after anterior total hip arthroplasty, these would be all the things that you may have heard from people who had a hip replacement and said, my doctor said I can't bend over at the waist, I can't sit and cross my legs, I can't twist my body. Those all apply when the hip is replaced via different methods, oftentimes from what's called a posterior approach. The anterior approach does help to eliminate some of those things, so it simplifies some of the instructions after surgery, as well as some of the precautions, predominantly the things that affect the risk of dislocation. That's all I had on the hip. Hopefully that was helpful, and I'll look forward to your questions at the end.